So hi everyone. Today we have another special VMR, this time with Family Medicine. For that, we'd have Dr. Ramla with us, and I would love if she could introduce herself and talk a little bit about family medicine. Please go ahead, Dr. Ramla.
All right, thank you for having me. I'm Ramla Kasozi. Currently, I'm a family medicine physician at Mayo Clinic in Florida. I completed my residency at the University of Minnesota. I hope you're able to hear me well. Um, and so family medicine is a really cool discipline because I feel like it's full spectrum, meaning you can do obstetrics, you see ped patients, you also see adult, you take care of chronic conditions. Some individuals decide to do more of a hospital type base for acute medicine. So that's a good aspect to a family medicine that you can be very broad or you can just be very narrow as well. Within family medicine, after your training, there are options to just continue and become a family medicine physician, or you can do fellowships. Some people do sports medicine fellowships, addiction medicine fellowships, whole kind of fellowships. For me personally, that I didn't do a fellowship. I just decided to work, but I'm more in the also teaching environment, which is kind of cool, which I really like as well. But I'm originally from Uganda, so I am a international medical graduate. So it is possible to, be an IMG, go to the residency and do all these cool stuff. So yeah, that is it about me. Today we do have a case. I think what we need though is a discussant. It'll be cool to have like another person around. I wouldn't want to be the only one speaking. The other option we can try to do is, which I think just because of time, because I have an afternoon clinic, um, Rafa can present the case, we can talk about it, and then, you guys could feel free, please, to engage, ask questions. We can learn. The reason why I like clinical problem solvers, I've been with it since I was a resident. I just love this very warm environment, very nurturing environment of learning. And you shouldn't be afraid to make a mistake because I think here we're very supportive and we kind of give you other ways to think about things. So please do engage as well. Anyone want to discuss, or do you guys just want to discuss together? Because I think we have a pretty good size. Yeah. Can we discuss together? I'm going to make the decision, like we just talk and float amongst ourselves. But since we're going to discuss together, I might just point out your name if that's okay and see what your thoughts are. This is not me trying to put you on the spot, and I hope you don't feel pressured. This is me just wanting to hear you and your voice and not my voice. Okay. All right. Rafa, you can go ahead.
Okay, so this time, since Dr. Ramla has a little bit short of time, we're gonna go like Thursday VMR. So this is a 38-year-old female, just I don't know how to say that in English, but it's like G5P4. I guess it's just a
Yeah.
five par five
Mhm,
par four.
mhm.
Um, with past medical history of gestational hypertension, presenting one PPG day 5 with headache and back pain.
Okay. So
I
go
can
ahead.
give you the history of present illness as well to
Sure.
give you a little more of background. So um, this patient was brought from a lactation visit because she appeared uncomfortable, and the headache began today and wraps around her forehead with no visual symptoms. This patient also endorses back pain, more on the left side, and also endorses pelvic pain. On the review of systems, no fevers, nausea, vomiting, abdominal, vaginal discharge, bleeding, normal bowel movements, no dysuria, frequency or urgency. The past medical history I already told you, the gestational hypertension, and she had a stat post NSVD. She had epidural, delivery notable for a cord avulsion, which required manual placental extraction. and she received cefoxitin 1 time. And that's the end of the aliquot.
All right, this is wonderful information. Thank you for that. And so for me, my approach, especially with pregnant women, gravida 5 para 4, that literally means like G is how many times they've been pregnant. So we can see that she's been pregnant 5 times, but it says para 4. So most likely, usually there are other numbers following to let you know if there's some sort of like history of abortion or miscarriage. But let's just assume she's had 4 she has 4 living children. So number 5, when it says gravida 5, that means, okay, she's currently pregnant. So that tells me, okay, this is a pregnant woman. And then also that she's having this headache. Oh, sorry, I think it got deleted. What was it? Headache, back pain, and whatnot, right? I always get concerned for pregnant women when they have this sudden onset of headache or these back pains or sometimes even pelvic pain. The reason is one of the conditions that you have to watch out for is hypertension, especially in pregnant women, especially when they present with headache. And the question is this hypertension something that was known, or was it something that developed in pregnancy? So the great thing is with the past medical history, it does offer that there was gestational hypertension. And a lot of research has shown that if a woman has had some sort of gestational hypertension during a pregnancy, most likely they'll have another gestational hypertensive episode. So by definition, gestational hypertension is actually occurring after 20 weeks of gestation. I'm not sure if you provided that information, so I'm not even sure what her gestational age is. So it can let me know, is it before or after?
38 weeks.
Oh, sorry, there it is. Okay, thank you. Now I see it. So 38 weeks. So she's above 20 weeks. So that tells me, okay, yes, this is most likely gestational hypertension. If she was under 20 weeks and having hypertension, maybe with a high blood pressure, then I would think, okay, this is probably chronic hypertension. But so in my head, I start thinking, okay, there's a headache. I have to make sure she's not hypertensive. Good thing is she's not having visual disturbance, which is reassuring. It doesn't look like she's having a febrile illness, which is great. Other differentials, especially the fact that she has pelvic pain, is she in labor or not in labor? That's another thing I got to figure out. Or is there a vaginal, discharge associated with that? Those are things you kind of look out for. Could it be a urinary tract infection and whatnot? So those are kind of things in my head. Any other ideas from the audience? I see that Hans, you're thinking this looks like preeclampsia. Please share, please unmute and share your thoughts.
Yeah, that was just the first thought when I looked at everything. She has hypertension, she has a headache. Now we don't have a urinalysis and all the other things, but no nausea, vomiting. The back pain I can't kind of associate with anything important, but 38 weeks pregnant, if I'm correct, then it's possibly, unless she was hypertensive before 20 weeks, and usually that pretty much might indicate preeclampsia as the worst case scenario in this situation.
Okay. Yeah, those are great thoughts. Those are things, as you probably, some of you may know, whenever I approach a case, I'm like, okay, what is the thing that I cannot miss? And the reason why I don't want to miss it, because I don't want it to cause a mortality issue, right? Especially when it comes to maternal mortality, you got to make sure you can quickly identify preeclampsia, but not even just preeclampsia, like severe preeclampsia, because that has a really significant mortality. So watch out for that. Any other thoughts somebody would like to share? Yasmin, do you have anything to share?
I'm also thinking about preeclampsia, but other see first. Whenever I saw a pregnant patient on my consult, I will be asking blood pressure measurement, and then urine test, laboratory analysis to see if how is the creatinine levels or liver function tests. Like always, hypertension in pregnancy it makes me nervous, honestly.
Yeah. Yeah, and it should. I also get nervous. So great, great points you've listed, Yasmin. I hope that's how I say your name. Is it Yasmin? Okay, great. Thank you.
That's the way.
Great, thank you. Okay, Rafa, go ahead. Any next quotes?
Yeah, amazing thoughts, by the way. So I provided you 2 aliquots and we have 3 more to go. I'm gonna give you the third one. So vital signs for this patient, temperature was 100 Fahrenheit. Her heart rate was 104, respiratory rate 12, blood pressure 130/68, and she's saturating 98% on rumor. Physical exam, generally speaking, this patient is tearful due to the pain. She has back bilateral CVA tenderness, more on the left than in the right. No spinal midline tenderness. Her lungs are clear bilaterally. Heart exam tachycardic, regular rhythm, no murmurs. Abdomen, tenderness to palpation in the right upper quadrant abdomen. Epigastric also is pubic areas. Extremities, no edema, no rashes, and pelvic exam was declined by patients due to discomfort. I have 2 more aliquots, one with the labs and another one with imaging. What do you want to discuss now, or provide later?
Let's talk about this one, and then we'll go into the
Awesome.
labs, right?
Awesome.
Great. So this is what I call great information because it's kind of shifted my framework. You know, the fact that she's tearful in pain, we see that she's like just looking at the vitals themselves, right? She's tachycardic, and even, you know, her temperature is up there as well. It makes me concerned now, is there an infection happening? Especially considering that she's having this pelvic pain or back pain as well that wraps her on along with the headache. And so I start thinking, okay, what could be the most common reason a pregnant woman could have an infection? Usually it's like the urinary tract infection, which can become complicated like pyelonephritis. And a complicated urinary tract infection usually is characteristic of like flank pain. Yes, they're febrile, they could be tachycardic, and they're just generally just not well. Of course, labs will also help to prove that. So I know in this particular woman, I know I will need a CBC and a UA, even urine culture, because I'm concerned about a severe, like Hans mentioned, you know, pyelonephritis. Speak on that, Hans. What are your thoughts?
Yes, when we got the second or the aliquot with the vitals, fever, or a mild fever anyway, and then of course the tearful due to pain, and then costovertebral angle tenderness. There is a strong indication for pyelonephritis, but the epigastric pain doesn't quite fit. However, UTI is quite common in women who are pregnant, so now we have to include a pyelonephritis as well into our differential.
I totally agree with that. Definitely, we have to consider pyelonephritis. Anna, from the audience, do you have any thoughts? What are you thinking?
Oh, hello, guys. Just to introduce myself, my name is Anna. I am from Brazil, and thank you for the opportunity. I think in this patient, I could think, because she doesn't have fever, but she's tachycardic. I was wondering if, about nephrolithiasis, kidney stones, because she's tearful due to pain. So it called my attention, and just to brought our differential diagnosis. She's tachycardic. She's not hypoxemic, but just to think a little bit more like pulmonary embolism or something like that. She doesn't have respiratory distress, but just to remember this diagnosis, just that.
Yeah, those are brilliant thoughts, Anna. Excellent. I like the fact that you mentioned some vascular component because we can't forget that, something like pulmonary embolism or thrombophlebitis or anything can cause a fever. So not only infections, they can be a vascular issue. So far we're kind of in the heads. We were first like thinking of, could this be like a preeclampsia sort of picture? But we see her blood pressure is pretty okay. But I think we still have to wait for labs because we don't always use blood pressure to diagnose some sort of like hypertensive disorder in pregnancy. But because of this abdominal discomfort or pelvic pain and back pain, now we're thinking, okay, could this be pyelonephritis, bacteremia? But you've also entered that element of a vascular problem that could also be causing these symptoms as well, especially with pregnant women. As we know, blood flow is not quite as, they're prone to clots, let's just say. Sometimes in pregnancy, it's a hypercoagulable state. That's what I was looking for. So things we have to watch out for, that's very important, is could this be a manifestation of a clotting issue that's causing all of this? And so that's what we have to think about too. All right, Rafa, do you want to add some labs?
Sure, sure. I think it's really incredible what you just said, that we have to think that pregnancy is also a hypercoagulability state, right? So increase the predisposition of clots in these patients. So adequate number 4 is this CBC. Oh, the white blood count is 13.2. And all her labs were normal, like platelets, AST, ALT, urine protein creatinine ratio. And the urine culture was made and came back positive for staph aureus. And I have one more aliquot that will reveal the final diagnosis.
Oh, wow. Okay, so this is some juicy information. Anyone from the audience want to talk before I kind of react? Please feel free. This is a warm environment. Share your thoughts, please. I see there's Ravi. Are you able to speak? Are you able to unmute? Hi, thank
Hi, how are
you.
you?
Good, welcome. Can you please share your thoughts?
Sure, I was sort of hiding in the background, and
Oh,
yeah, very very intriguing case. We've had a few pregnancies with hypercoagulable disorders, just like you mentioned. Hypercoagulability definitely can be demonstrated in pregnancy, but we can't forget other organs in the vicinity in that right side. So definitely some of the chat mentioned pyelonephritis, cholecystitis, cholangitis. I remember during my surgical rotation, we had some pregnancies with gallbladder disease. So that definitely comes to mind. So those were a few thoughts. And maybe some esoteric features, maybe they could be bacteremia, just because there's a fever, I guess a white count of 13. So bacteremia resulting in maybe abscesses that could also be in that vicinity as well. So a few thoughts that I have. Thank you.
yeah, those are great thoughts, and I appreciate that too. And I think we just have to remember that there are various things that can cause a fever, somewhat of a fever. It's also various things that could cause tachycardia and, tachypnea. So I think we're covering most of them, which is great. Especially this is a very unique patient, a person who is pregnant. Not only is it a hypercoagulable state, some even consider it a very immunosuppressive state. So we have to also be mindful of the various types of infections they can get. The organs just themselves shift in places they've never been before. And so who knows what could be happening in those areas as well. All right, great. Any other thoughts before we move on to the next aliquot? All right. Okay, Rafa, I think you may have to add the last bit.
Okay, so I think I can hide a little bit of the diagnosis by
Yay.
sharing the ACT scan. ACTs show the left ovarian vein thrombosis extending from the left adnexal to left renal vein, and mild bilateral urethral enhancement. And the TT was negative for this patient. And the next aliquot will read the diagnosis.
Okay, this is interesting. I'll be honest, I've never seen a case like this. I don't even know how common this is, to be honest. This left ovarian vein thrombosis extending from the left adnexa to the, I mean, that I've never seen, just even reading it. I suspect, like we said originally, I mean, theoretically, yes, pregnant women have this hypercoagulable state. I just didn't know that a thrombus can actually, happen in the ovarian vein. Why that happened is very interesting too. I'm wondering if there was some sort of like anatomical reason for that. And I feel like there is. Does Ravi, you're mentioning something here about varicosities of the veins, you think?
Yeah, I guess you mentioned a really important point with the anatomical changes that may happen. So varicosities in those areas could be a predisposition to developing this, plus with the added layer of hypercoagulable disorder.
Yeah, that's a great thought too, as well. I totally agree with that. And whether or not could there be like a translocation of bacteria or flora? I don't know. That's also another thing too. Any other thoughts from the audience? Hans, you kind of stated something here about stasis in the veins may increase pregnancy plus estrogen is high.
Yes, I mean, I'm really surprised to see that she had, and it was an excellent thought that came up, that we need to keep in mind a hypercoagulable state. Now, if this lady, for whatever reason, and Ravi mentioned it, has varicose veins, then of course pregnancy might make the stasis more pronounced, and of course pregnancy is in a high estrogen state, so this causes a hypercoagulability. So that would all fit. It's just mind-boggling to see it in your ovarian vein. It's just really great.
Right. I know, because I feel like the ovarian is so deep into the pelvic structure, right? Like you would have expected something a bit more, peripheral or superficial kind of. So this is quite interesting. And then what do you guys think about this mild bilateral urethral enhancement? I mean, that I kind of worry about too. I mean, does that mean there's some sort of local inflammation, therefore still supporting our thought of could there be a pyelonephritis? What if there is like two things happening here versus one? So I don't want to ignore that as well. Like I wonder if there is some sort of, infection, and which I think, let's assume even if this was pyelonephritis, especially in a pregnant woman, one of the common organisms is, Staph aureus. So this could be a bacteremia on top of, now we have some sort of like vascular issue happening here, like a clot process. Any other thoughts? And yes, Ravi, speak to that. You said something about infections can cause thrombophlebitis.
Yeah, I'm just sort of echoing what you mentioned earlier, which was actually a picture of thrombophlebitis, which could be due to inflammation, or it could be, like you just mentioned, is there infection of the kidney, maybe a neighboring structure, maybe the uterus. So if there's some sort of intrauteral or outside the uterus, if there's an infection that could trigger inflammation of the vein and stasis and a clot, or it could be an infected clot within the vein. So kind of murky. I've not seen this before, but
yeah,
very interesting.
Very. I totally agree with you. Inez, or is it Inez? I'm sorry if I pronounced your name wrong. Are you able to unmute and speak on sort of your thoughts I see here? You're discussing about polycythemia or amniotic fluid embolism. Do you want to speak on that? It's a warm environment, but I understand if you're not ready to. Oh, you looks like you're unmuted. Oh, your mic is not working. That's fine. Okay. So maybe I'll just mention that you're sort of wondering if could this be an amniotic fluid embolism, but something short, or polycythemia. I mean, also a possibility as well. I guess for me, what I would also want to figure out in the vitals, I don't know if we mentioned, I'm very much about, what is the fetus, like how is the fetus right now? Where are the strips? There's something we call the NSTs and, just fetal tracings. I don't see it here mentioned, but I'm assuming maybe it wasn't too bad. that they had to mention it. But definitely I would want imaging just to make sure the baby's okay. And the uterus is fine too. Yes, Hans, you're right. We need an ultrasound. Okay, with that said, Raf, I think you may have to bring us home.
Yeah, incredible discussion as well. You guys are going the right direction, by the way. So the final diagnosis was Staph aureus bacteremia. The source being the pelvic vein thrombosis. I'm sorry, thrombosis related to septic pelvic thrombophlebitis, like you guys were saying, and seeded from endometritis. Differential diagnosis seeding from neighboring urinary tract, but giving no urinary symptoms. The suspect that this was not the initial source, but whether a metastatic site of infection. And that's the end of the
Wow.
case.
That is a pretty good one. And it's almost like we were, as we were discussing earlier, how that's anatomical sort of, relationship, that this started in urinary, but somehow became complicated and became septic and then led to all of this cascade. Wow. So this is an example of where, sometimes, you start with a case with a particular idea, and I think we just took a full, if not 180, but 360 on, okay, this was more of an infectious slash septic pelvic infection and thrombophlebitis. Great. Thank you for this case, Rafa. This was amazing. Any other thoughts from the group? Like, what are your thoughts behind all this diagnosis? I mean, I've never seen anything like this, honestly, and I hope the woman who went through it is okay, because this is could be very uncomfortable. Ravi, any last thoughts?
I know, I thought this was a remarkable case. I deal mostly with medicine patients, but occasionally we are called over to OB and manage patients. And I had recently had a case of amniotic fluid embolism, somebody managed, but something to be on the lookout for. But I've never seen this. Actually had on my service somebody with a DVT PE, massive PE, but I guess clots can happen anywhere, especially in the presence of infection. So I really appreciate the case, Rafa. Really, definitely learned a lot, and also Ramla, great facilitating. Definitely learned a lot of good points.
Thank
Thank
you.
you.
All right, this is excellent. Yeah, thank you. I've also learned, I mean, I've never seen this. So this is like also helping me to become a better physician and to, like Ravi said, just be acutely aware of that. That's just something now I need to move up to my diagnosis that, okay, she may have a UTI, but let's hope it doesn't become complicated and cause some sort of vascular issue, Okay, with that said, maybe, are you ready to talk about the teaching points?
Yeah, it's Sammy.
Oh,
Please go ahead,
Sammy.
Sammy.
Okay.
Yeah, sure. Thank you so much, Rafa, for this case, and Ramla, amazing discussion, and also the chat was on fire. So thank you all so much. I will just go over some quick teaching points. We approached headache in pregnancy. We have to think about the primary headache forms, but also about hypotensive emergencies or crisis, but also about acute avascular events, for example, cerebral venous thrombosis. When we approach gestational hypertension, its definition is that it occurs after 20 weeks of gestation, and there are some syndromes that we have to keep in mind. And we always should be concerned for HELP syndrome, which stands for hemolysis, elevated liver enzymes, and low platelets, preeclampsia, which is new proteinuria in the onset of the new onset hypertension, and eclampsia, which is the most complicated form and associated with seizures and neurologic complaints. When hypertension occurs before 20 weeks of gestation, it's called chronic hypertension. Infection in pregnancy, we should prioritize urinary tract infection because pregnancy predisposes to it. It also explains the need for UI for urinary analysis in the beginning of gestation, because it can increase the risk of preterm delivery. And that's also the reason why asymptomatic bacteriuria should also always be treated in pregnancy, also when the patients don't have any symptoms. Pregnancy also predisposes to hypercoagulability, DVTs, pulmonary embolisms, and it also shifts organs, so pain is much more vaguely localizable than it is anomaly in the abdomen, for example. Other causes of hypercoagulability include neoplasia, nephrotic syndrome, OCP use, etc. Then we had this rare entity of ovarian vein thrombosis, which most often occurs in the peri and postpartum phase, and 80% occur on the right side. It's a cause of acute right-sided lower or upper abdominal pain, and it's very important to also keep genitourinary causes in the differential of acute abdominal pain or CVA tenderness. So thank you all so much and have a great day.